Philosophers and brain scientists throughout history have reflected over what consciousness is and what it is not. From Aristotle to Francis Crick, they have debated where it resides and what it means. But the jobbing neurologist is not bogged down by such philosophical discourses. Faced with a patient struggling to remain conscious, such musings seem esoteric. In this situation, neurologists intuitively know what consciousness is and what it is not. The questions that agitate their minds in these circumstances are what is impairing it. The neurologist is not overly bothered by simple faints, seizures, and concussion in which consciousness is only transiently disrupted. What agitates them is when impaired consciousness becomes entrenched. So here is a countdown of 10 persistent disorders of consciousness that aggravate neurologists. 1. Encephalitis. Encephalitis is infection of the brain substance itself. It is distinguished from meningitis, which is infection of the covering of the brain called the meninges. But in some cases, both are infected, thus the name meningoencephalitis. For some reason, encephalitis is predominantly caused by viruses, and this is unlike meningitis, which is usually caused by bacteria. And many viruses are complicit in causing encephalitis, from dengue and Japanese bee to West Nile and rabies viruses. But the top dog, without any doubt, is herpes simplex virus type 1, a pathogen that has an affinity for the temporal lobes of the brain. Apart from impaired consciousness, encephalitis also presents with seizures. The outcome of viral encephalitis is best the earlier treatment is started. Otherwise, there is a risk of mortality as well as post-recovery amnesia. Encephalitis is therefore a state that screams for an early diagnosis and prompt treatment. Number 2, delirium. This is defined as a disturbance of attention and consciousness and is characterized by impaired ability to direct, focus, sustain, and shift attention. Delirium usually occurs over hours to a few days, and it tends to fluctuate over time. People in the throes of delirium may be hypoactive or, surprisingly, hyperactive, or they may have a mixture of the two. Characteristically, their thinking is disorganized and they are very easily distracted. They may also manifest with illusions and hallucinations. Almost anything that disrupts the body system, from infection to metabolic derangements, can cause delirium. Delirium is therefore not a diagnosis. It is a call to arms to unearth the underlying culprit, and a big challenge that is. Number 3, Wernicke's encephalopathy. This is a disruption of brain function which manifests with confusion, amnesia, and characteristically confabulation, making it up to cover for memory impairments. Examination typically reveals something we call ophthalmoparesis, which is weakness of the muscles that move the eyes. Nystagmus, jerky movements of the eyes, may also be seen. Although the classical cause of Wernicke's encephalopathy is alcoholism, the list of triggers is much more extensive, from malnutrition and starvation to bariatric surgery and hyperemesis gravidarum, excessive vomiting in pregnancy. Wernicke's encephalopathy challenges the wits of neurologists to identify a cause and to treat the diverse manifestations. Number 4, posterior reversible encephalopathy syndrome, or PRES. This is a brain disturbance that predominantly affects the posterior or the rear end of the brain, and which thankfully is potentially reversible, as the name implies. But that is only if the neurologist can identify the cause from an almost impossibly long list of potential culprits. And this list includes such disorders as cancer, sepsis, hypertension, and preeclampsia. PRES typically manifests with headache, seizures, visual disturbances, and impaired consciousness. All vague and non-specific symptoms that challenge the neurologist to even think about the diagnosis. Number 5, osmotic demyelination disorder, or ODD. In this disorder, there is loss of myelin, or the covering of the nerve fibers, and this usually occurs because doctors have corrected low sodium too rapidly. Classically, the abnormality is in the middle of the pons. This is the middle part of the brainstem, and this accounts for its former name, central pontine myelinolysis. And the manifestations of ODD beyond impaired consciousness include difficulty with speech and swallowing, weakness of all the limbs called quadriparesis, and even the locked-in state. But the above is an oversimplification of what is a more complex problem. For one, the causes are more diverse, and they range from low sodium itself to countless medications. And for another, the pathology may be located outside of the pons, such as the thalamus, basal ganglia, the cerebellum, and the spinal cord, all aptly covered by the name extrapontine myelinolysis. ODD is, to state the obvious, a challenge to sort out. Number 6, Hashimoto encephalopathy. This is brain impairment resulting from disorders of thyroid function. And the usual culprit is, no surprises here, Hashimoto's thyroiditis. Graves' disease may, however, also lead to Hashimoto encephalopathy. All sorts of antibodies have been identified as the causative middleman for this condition, and these include antithyroid microsomal and antithyroid peroxidase antibodies, amongst others. Apart from impaired consciousness, other manifestations of Hashimoto encephalopathy include seizures, stroke-like episodes, and hypersomnolence or excessive sleeping. Hashimoto encephalopathy requires the neurologist to think very well outside the box. Number 7, chronic traumatic encephalopathy. This is a progressive neurodegenerative disease that may result from a single or more often from repetitive closed head injuries. And it is no surprise that contact sports are the settings for this disorder, which manifests with impaired concentration and attention, disorientation, and confusion, along with a host of psychiatric problems from apathy to depression. No wonder it is a difficult one for neurologists to sort out. Number 8, vegetative state. This is a state of wakefulness but with absent or reduced awareness, which has lasted at least 4 weeks. There is preserved spontaneous or stimulus-induced arousal, but there is no awareness of self or of the environment. It is classified as permanent if there is a metabolic or anoxic cause lasting more than 6 months, or if there is a traumatic cause lasting more than 1 year. Number 9, minimally conscious state. This is another prolonged disorder of consciousness similar to vegetative state, but with the difference that there is preservation of awareness of self or the environment. Affected persons may interact with their environment, but this is inconsistent. Both vegetative and minimally conscious states are a challenge for the neurologist to identify and to manage. And number 10, coma. This is defined as unrousable unresponsiveness in which there are no sleep-wake cycles. The eyes are usually closed, but there may be slow eye-opening movements. Suffice it to say that almost anything that disrupts brain functioning can lead to coma. The challenge for the neurologist is to determine reversible from irreversible causes and to treat the former aggressively and to manage the latter sensitively. Thank you for listening or watching this podcast. If you found it enlightening, do click on the like button and subscribe to the YouTube, Spotify, or Apple channels of the podcast to ensure you don't miss the next episode. And whilst waiting for that, consider reading my book, Surfing the Brain, or checking my website, Neuro Checklist. Thank you very much for your attention.